is David Jones. I'm Professor of Bioethics at St Mary's University in Twickenham, and also I'm Director of the Anscombe Bioethics Centre in Oxford. And I'm here to have a conversation with Dr Dominic Whitehouse, who is a palliative care physician on the South Coast.
So that's me, Dominic Whitehouse. I worked in palliative care for the last 10 years in our local hospice on the South Coast, near where I live. Before that, I worked all over the world in the military, in the NHS.
How would you define palliative care? What is, for people who are not familiar with it, how would you characterise palliative care?
Well, palliative care is it's basically a shift of focus, really, from curing, which is what most of medicine is about, operations and powerful anti-cancer drugs and things like that, to more of a healing and supportive role of medicine, looking after the whole person. We look after their physical symptoms, and that's where the word palliation, palliative care, came from. A cloak in Latin is a pallium. So we cloak the symptoms, the physical symptoms at the end of life that people are suffering from, be that pain, shortness of breath, anxiety. But also, we look after other aspects of the person. So we look after their spiritual needs, their social needs, their psychological needs. So it's a holistic branch of medicine that's very, very satisfying to be involved in, but very difficult to get right sometimes.
How does the United Kingdom rank in terms of palliative care worldwide? I mean, where do people look to the United Kingdom?
Palliative care really grew up in the United Kingdom, and it was put onto modern footing by Dame Cicely Saunders, who's a very impressive lady, and her mantra, if you like, which actually best illustrates the ethos of palliative care, is that you matter because you are you. You matter until you die, and we're going to do everything we can to give you a peaceful death, and also to make sure that you enjoy living until you die. She started to research the different kinds of painkiller at the end of life and the impact of other social and psychological supports, and slowly built up what is now perceived across the world as being the best system of palliative care in the world. There's a paper by a chap called Finkelstein who did a ranking exercise of all the different places where palliative care is done, and you can see that Great Britain, is #1 and has been in previous studies by other people as well since they started looking at this.
If we have this wonderful model, and if it can do so much, why is it that we still hear stories of bad deaths?
Not everybody in the United Kingdom who would benefit from palliative care is allowed to have it because there isn't enough provision. So we have about 200 hospices in the UK, and most palliative care in the UK is based on hospices. Those 200 hospices generally look after around 300,000 patients per year. The studies show that there are at least 100,000 people who are missing out on that care and who would benefit from it. And the reason they don't is because it's underprovided. Most hospices and most palliative care services in the UK are not paid for fully by the NHS. In fact, they only get about a third of their money from the NHS.
How is hospice care, palliative care being affected by the general crisis in the NHS that we hear about at the moment?
The amount of money that's spent on palliative care in different parts of the country per head of population varies between about £10.30 and 27p. To have to rely for such an important part of people's care being paid for by charity in a modern, civilised, developed country is actually scandalous.
What are your views, what are your concerns about a change in the law in relation to assisted dying? That is either assisted suicide, which is either physician-assisted suicide where the patient takes a lethal drug, or euthanasia, that is where a doctor gives a lethal injection to a patient on request. It's very much being discussed at the moment in Parliament. How would you view the concerns that people in palliative care have about this change?
Three main aspects, really. There's the impact on the patients and the people who are nearing the end of life. There's the impact on the professions, medical profession particularly, and there's the impact on wider society. I mean, particularly as regards our patients, there's the risk that the important trusting bond between a doctor and the patient will be torpedoed completely. And if I have to go to a patient and they know that I'm thinking about assisted dying, I don't want to see the fear of that in their eyes.
Yes.
There is this immediate impact on people who are under palliative care at the moment, but there's the ongoing potential to undermine, the therapeutic bond between doctors and patients that's been built up over, millennia since the Hippocratic ethos.
Some people who were in favour of this bill, they say, well, if you look at other countries, all of these bad things haven't happened. We might be afraid of it beforehand, but if you actually look at what happens, it hasn't turned out like that.
Well, I'm not sure that's quite right, though. I mean, I've got a friend who's a palliative care professor in Canada, and she's told me all sorts of horror stories about it over there. Doctors are actually leaving the profession because they're being expected to be involved in it either directly or to refer people for it.
Yes.
More immediately, perhaps, of interest to the UK is Oregon, where the doctors who are actually performing assisted dying have only known the patients for an average of 6 weeks. It's not the usual doctors that are involved, it's doctors who are happy to do it. In Oregon, like in the UK, most doctors want nothing to do with it whatsoever.
Yes.
And therefore, you have doctors who don't know the patient involved. How can they possibly check for the safeguarding things like coercion, elder abuse, things like that?
In the bill that is proposed at the moment, the Leadbeater bill, there's no mention of how long the doctor might have known the patient, or indeed whether the doctor is a specialist in the care of the patient, only that the independent doctor can't be involved. They exclude people who know about the patient, but there's no provision for there ought to be somebody who knows about the patient.
There's very chance for the family to input to the process as well. In fact, they're almost excluded deliberately, and it's very much a conversation between the doctors and the patient. There's no call for the family, the wider family, to be involved.
Part of the reason for this conversation, for talking about your experience, is that I went back to the House of Commons Health and Care Committee report, which had a committee on, it called itself Assisted Dying / Assisted Suicide, because they wanted to be even in their language, even-handed in their language. And they gathered a lot of good evidence, a lot of very interesting evidence. But on the question of the impact of palliative care, they said that they hadn't seen any negative impact. I looked at this, but I found that a lot of the evidence was actually from quite a few years ago. So there was evidence of a few years in Belgium of increasing provision. But more recent evidence after the systematic review, which is mentioned in the report, and evidence even that's come out since the report has come out, has painted a rather different picture in relation to the provision, and in relation to the funding, and in relation to quality. So in all three areas, there is new evidence which either wasn't put before the committee or has come out since, or for one reason or another was obscured by just how much different pieces of evidence they had. In relation to provision, which is perhaps easier to see because it's quantitative, you can look at provision in number of services, of different kinds of services for palliative care across Western Europe. And over the last 14 years, in countries with assisted dying, with either euthanasia or assisted suicide, it has increased. It's increased by about 8%, I think. But in countries without this, it's increased by 25%. So there has been an increase. You can still have an increase at the same time as you have this, but in Western Europe, in the most recent evidence, it's countries without euthanasia or assisted suicide which have had a greater increase, and it's the same in the United States. So in the United States, there are, well, the last audit of end-of-life care of palliative care rather in the United States, which I think 2019. At that point, there were 7 states with physician-assisted suicide. So you can say, well, between that one and the previous audit in 2015, what happened in those states and what happened in all the other states? And the answer again was, well, there was an increase in those states, but there was a greater increase in the other states. So there seems to be actually an inhibitory factor, even in relation to provision.
And my understanding is that that's reflected in funding as well. The amount of funding that goes to palliative medicine differs depending on whether you're an assisted dying state or a non-assisted dying jurisdiction.
This varies very much jurisdiction to jurisdiction, and often if there has just been a change in the law, the change in the law is a time when people have conversations about end-of-life care, and it's often a time when people realise that they're underspending on palliative care, and often have been underspending for many years. So whatever the result, whether when debating it the Parliament decides against going down this road, or the Parliament decides to go down this road, whatever the result, it's an occasion to think, but whatever happens, we need to spend money on palliative care. So it can be the discussion, not changing the law, but the discussion can be quite useful. But what you find is over a few years later, that places that have promised money when they've changed the law, the money hasn't necessarily materialised. So in New South Wales, for example,
in Australia,
in 2022, the law changed, and they promised when the law changed that palliative care would have an extra 743 million Australian dollars. So $743 million more to be spent on palliative care over a 6-year period. It was very widely reported, and the reports of this are also reflected in the House of Commons report. But what isn't in the House of Commons report is what actually happened later, which is that in the autumn they revised the budget, and then in the beginning of this year there was a cut of $249 million in 1 year. So what actually happened is that across most areas of New South Wales, palliative care services were cut, but the budget was cut by 30%. And that meant actual staff cuts, and that meant real cuts to palliative care after this promise of an uplift. So promises don't always come.
No, exactly.
They don't always come. When an issue is discussed, like where palliative care is discussed, then it goes up in the agenda because people's attention is caught by it, and then they realise it's underfunding. But then what happens later on is then it has to compete with all of the other people who are looking for money, and in a health service which is often looking for money. And then you find in countries which have had changed their law, they now have extra money that they have to spend on rolling out assisted dying, on training people, on delivery, on bureaucracy, on oversight. This all takes time and this all takes money. And the money is now coming out of the end-of-life care budget, which is both the budget for palliative care and the budget for assisted dying. So money is effectively diverted from one to the other.
There is an understanding, or a suspicion is it perhaps, that actually one of the benefits, if you like, of assisted dying is that it will actually save money in the long run, because people who are consuming a lot of resources at the end of their lives, and it's known that people in the last 6 months of life use resources at a much higher rate than any other time, that a lot of money might potentially be saved. And in Canada they actually did the health economics assessments of that beforehand. But of course that money doesn't necessarily go to palliative care.
Exactly,
it gets eaten up by the rest of them.
So it is true that there is a cost of living. To live is to consume. It is true. And if we have need for care, if we have need for nursing care, if we receive a pension, if we have property, that as we live, so we consume resources. That's part of what those resources are for. Doctors are for
sick people.
Sick people.
Yes.
Sick people don't exist for the sake of doctors. Doctors exist for the sake of, and so also with social care. But it is the case that if people died earlier, as many older people did during COVID, if people died 6 months earlier or a year earlier, then this saves not just social care, it saves in pension, and it saves in... But those savings, rarely are they from palliative care. So palliative care often actually has an increase in costs because more people are interested in palliative care when you talk more about assisted dying. But now it's got to compete with assisted dying for its budget, and so money's being saved, but it's being saved somewhere else.
And what about the actual quality of the palliative care that is bought with the money in the jurisdictions where...
Quality is the more important question. Quantity is important because of access, that we don't have enough access to palliative care. But fundamentally, palliative care is all about quality. And so the question is there an impact on quality? There are different ways in which you can assess this. There are studies, qualitative studies, and they interview patients or interview staff, and they say, well, it can sometimes help because it might provoke people to ask questions and then be more honest about the sort of conversations. But it can also make conversation more problematic, particularly if not all the relatives agree. It would mean, for example, people hiding things from their relative because they and their relatives don't agree about this. If different doctors have different views, then the relationships of the patients with the different doctors can become more complicated. And also sometimes patients decide if they're going down this route of assisted dying, then they are more anxious about symptom control. They're more anxious about, say, pain relief, because they want to make sure that they can pass the assessment. And so you can get a disengagement from palliative care. And
we've seen, haven't we, in some of the reports, that actually people asking for assisted dying because of a fear of pain has actually gone up in many of the jurisdictions where...
It's gone up in all the jurisdictions
where
we have where it's recorded. So most jurisdictions don't ask people about their motivations. They ask if they're qualified by having certain diseases or so. But some jurisdictions, such as Oregon and Washington and Canada and now Western Australia, ask what was the motivation? Why were they seeking this kind of death? And often it's about wanting control or autonomy. Mostly pain is a less important reason. However, over the time, pain has become more important, which seems to imply that the palliative care in relation to pain relief, symptom relief, this is not being as effective, or at least people are more afraid of it, the longer you have assisted dying, the more people are concerned about pain, the more people have a fear of pain. So it's not helping people's symptoms.
And that could be because people are having more pain because they're not accepting the painkillers that would help them, because they want to keep a clear mind to sign the paperwork for assisted dying.
So there was a study done, I think, in Canada, and these are all professionals who were delivering medical assistance in dying, so it's not people who are opposed to it. But all of the professionals who were interviewed spoke about a tension between symptom relief on the one hand and assessment for medical assistance in dying on the other. So this was not a rare thing. And 2 other studies in 2 other jurisdictions did the same thing. So we see qualitative evidence and quantitative evidence pointing in the same direction, which is that it can cause problems for symptom relief, which is deeply paradoxical because concern about people's suffering is one of the things which is driving this debate.
Yeah, and there have been a few studies actually looking at the overall picture of a country's quality of provision of assisted dying, comparing them with each other, haven't there? I understand.
So you mentioned earlier that the United Kingdom has come top in a number of international comparisons of palliative care. Whether we can maintain this if we don't maintain funding is moot. But certainly at the moment, the United Kingdom is a beacon for palliative care. But if you look at countries which have changed their law on assisted dying, then between 2015 and 2022, most of them have declined. Most of them are further down the ranking. And this ranking is not just about number of doctors. This ranking is an attempt to look at quality of death. This ranking is looking at all kinds of quality assessment of what people's experience has been in these different countries.
They look at different domains.
And what they find is that, as I say, places like Belgium and Canada, they've fallen out of the top quartile. So if you have 80 countries, the top 20 that is the top quartile, and you would expect the richest countries to be in that, and Canada and Belgium used to be there, and they're not.
The United States has dropped precipitously, I'd heard, in that ranking as well, down to about 46 or something.
It has. This is part of a broader picture in the United States where no other country spends as much and has so uneven a result in terms of its healthcare. So the number of people covered in the United States has gone up, and the ranking of the United States in palliative care has gone down.